presentation. So thank you everyone for joining us for this presentation today. The presentation will be done by a group of students who worked on this project, Evaluation Tools for Visual Deficits in Adults with Acquired Brain Injury in the Rehabilitation Setting, the scoping review. So this question was submitted by clinical supervisors Ivy, Megan, Amélie, and Melanie, and under the supervision of Dr. Bussie. So done in the context of the McGill School of Occupational Therapy and Physiotherapy projects. So thank you very much for being here, and students, please go ahead and good luck for your presentation.
Thank you. Thank you for the introduction, and thank you again for Dr. Bussie, Ivy, Megan, Amélie, and Melanie for your help and support throughout this whole process for our master project. So here, we would like to start saying that in Canada, it is estimated that 1.5 million people live with acquired brain injury, or ABI in short. And visual deficits following ABI are highly prevalent. It is estimated that 50% of patients with ABI will present some form of visual deficits after injuries. It is known that inadequate visual evaluation can impact patient recovery. However, little is known about evaluation tools used across different disciplines in vision rehabilitation following ABI. So what exactly is ABI? So ABI refers to an injury to the brain that occurs after birth, and that it's not hereditary, congenital, degenerative, or induced by birth trauma. Individuals can experience the effects of visual deficits following ABI immediately after the injury, and symptoms may change over time. ABI is also categorized into two types: traumatic brain injuries, or TBI in short, and non-traumatic brain injury. So traumatic brain injury is caused by an external force, such as receiving an impact on the head during sports, motor vehicle crash, or a fall. And injuries can range from mild concussion to severe permanent brain damage. When looking at the numbers, studies have estimated that the annual incidence for severe TBI is 11.4 per 10,000. And the annual incidence for mild TBI is 600 per 10,000. When looking at the age group, a disproportionate number of cases occur in males aged between 15 to 24 years old. Regarding non-traumatic brain injuries, they are caused by an internal injury to the brain as a result of an illness, oxygen deprivation, metabolic disorders, aneurysm, and etc. We can think of stroke and also seizures. It can be also caused by a substance introduced in the body that damages the brain. Non-traumatic brain injury has a direct impact on cells throughout the brain and has the ability to spread to all areas of the brain, while TBI only affects concentrated areas of the brain. A study done by Kruger et al. Has estimated that 405,000 individuals experienced the effects of stroke in Canada in 2013. The prevalence, it is the prevalence of 1.15%, and the prevalence is increasing substantially with age.
Okay, so moving on to vision, a little background on vision. First of all, it's a primary sense with a very complex neurological organization. Different brain areas are responsible for different aspects of vision, and structurals integral to vision exist both within the cranial cavity and outside, such as the cranial nerves and afferent and efferent sensory inputs and outputs. When we're talking about visual deficits, we can be referring to issues with visual efficiency, visual integrity, or visual perception. So the ability of the eyes to move, the quality of information received by the brain, and the interpretation of that information. Unrecognized visual impairments can have major impacts on patients' recovery process and prognosis. So often what we see in the literature is that there has been inadequate visual screening in the clinical setting associated with ABI. And some reasons for that can be a lack of access to assessment by vision professionals who often aren't included in the rehab milieu. Also that there could be a lack of specialized training by rehabilitation professionals who actually are in that milieu. And that there are few rehabilitation programs in Canada that focus on evaluating and treating visual impairments following ABI, Quebec being an exception to that. There also can be a lack of knowledge and communication between disciplines in the rehabilitation setting as to how others are screening for visual deficits and communication of the results of those screenings. So for the purpose of our research, we used Mary Warren's 1993 hierarchical visual model to interpret our results. So Mary Warren is an occupational therapist. She developed this model based on a large amount of research and review on visual deficits following ABI. Her model is widely known and used to guide clinical reasoning and practice in this area. So her model says that visual skills are neurologically organized in a hierarchy with more foundational skills at the bottom and higher skills at the top. The function of those higher visual skills is dependent on the adequate function of the lower visual skills. Therefore, assessment and intervention can be carried out following this model to make the most efficient and accurate assessment and intervention. So going into what those different levels look like, on the foundational skills, we have things like oculomotor control, visual fields, and visual acuity. In the middle of the pyramid, we have intermediate skills such as visual scanning and visual attention. And at the top of the pyramid, we have high skills such as visual memory, pattern recognition, visual adaptation, and performance of visually guided ADLs.
So for the different evaluation tools, they are used to you use different evaluation tools to evaluate visual deficits with acquired brain injury patients. It could be diagnostic tools, which are often used by the eye care physicians to give or confirm a diagnosis. There's the screening tools that are simple tests that are used by clinicians to identify individuals with impaired visual acuity or other problems causing functional limitations. Generally, the screening tools do not require specialized training or equipment. There's also assessment tools that are used by the rehabilitation professionals to evaluate capacities, build intervention plans, monitor change over time, and document outcomes. So these tools aim to provide a comprehensive examination of the eyes and the associated structures to determine the physical cause of the impairment and also quantify the remaining visual abilities. So when selecting an evaluation tool, it's important to consider the use of standardized tests with normative information and demonstrated psychometric properties. So we wanted to do a quick overview of the different psychometric properties because it might be really far in your memory. So first, we have sensitivity, which is the ability of the tool to correctly identify people who have a particular condition. Then we have specificity, which is the ability of the tool to correctly identify people who do not have a particular condition. Following that, we have predictive value that can be split in two. There's the positive predictive value, which is the proportion of patients with a positive test result who actually have the condition. And then you have the negative predictive value, which is the proportion of patients with a negative test result who do not have the condition. After that, we have the likelihood ratio. So the likelihood ratio is the likelihood that a given test result would be expected in a patient with a particular condition compared to the likelihood that the same result would be expected in a patient without the particular condition. So again, you can have a positive likelihood ratio, which evaluates the likelihood of a positive result. And then you have the negative likelihood ratio that calculates the likelihood of getting a negative result. Following that, we have reliability, which is the ability of a tool to produce consistent results. There's multiple kinds of reliability, but we won't go through them today. And for the validity, it is the degree to which a tool measures what it claims to measure. And like reliability, we won't go through the different kind of validity today.
So to begin our project, we performed a preliminary literature search to see if there were already reviews on our topic of interest. And 9 reviews were identified. However, none of them encompassed all conditions of acquired brain injury, and they either focused on only stroke or TBI. Most of them also focused mainly on a small and specific area of visual deficit, such as unilateral spatial neglect. And most of the reviews also came from the fields of ophthalmology and neurology. So the objective for our scoping review was therefore to identify the evaluation tools used in the rehabilitation setting to evaluate visual deficits on adult patients with ABI, as this is something that has not been done before. We have also a secondary objective to report on the timeline for administering the tools in the patients with acquired brain injury. For the methods, we followed the scoping review methodology from ARCSI and O'Malley, which had mainly 5 stages plus 1 optional stage. So we first determined our research question and identified relevant studies through different clinical databases, as well as a search of the grey literature. And we then screened abstracts and full articles to select the studies that we would include, and we extracted all the data from our studies into table. And finally, we organized all of the information into tables and charts, which you're going to get to see soon. And this is really to summarize the tools and highlight all the important information. And so for this study, we decided not to carry out a consultation, which is the 6th and optional stage. To select our studies, we based it on a list of inclusion and exclusion criteria that we agreed on. So for study to be included, we made sure that the participant had a visual deficit that was caused by the acquired brain injury, that all the participants were at least 14, with the majority of them above 18. The study focused on the rehabilitation setting, and they involved tools used by healthcare professionals that was used to investigate visual deficits. We included only the studies that reported psychometric properties on the tools, and we only kept articles published in English or in French. As for exclusion, we did not keep the studies about population with visual deficit resulting from evolving conditions such as degenerative neurological conditions or brain tumors, as those could be unstable. Tools that only had a subscale on vision but did not primarily focus on vision, as well as neuroimaging assessment tools. And then we also excluded some studies based on study designs that were editorials, commentary, qualitative research, case report, or case studies.
So here we're going to present the main results of our search. So the search identified 2,531 articles across 4 different databases, which include Medline, Embase, CINAHL, and PsycInfo. We have also hand searched in the grey literature to find more articles, and we have identified 68 scholarly online resources. After removing the duplicates, the search yielded to 1,867 potentially eligible studies. Then we screened the titles, the abstracts, and the full text of the studies, and we excluded those that did not meet our inclusion criteria, and ended up having a total of 83 studies for the synthesis. Among the 83 studies, 75.9% of the studies were on stroke patients. The remaining 13.2% are on TBI patients, and 10.8% of the studies were on patients with mixed ABI conditions. 47% of the studies reported using batteries or multiple evaluation tools to assess visual deficits in their population. Also, from the 83 studies, 86 tools were identified. 70% of the tools has been researched on the stroke populations, and 50% on the TBI population, and the remaining on both stroke and TBI populations. No studies recommended an ideal testing time frame, which was an information that we wished to collect during the research. So here we use several diagrams to demonstrate the data. Here we have figure 2, a pie chart. It demonstrates the number of studies for each study design. We observed that most of them were cross-sectional studies, cohort studies, reviews, and diagnostic accuracy studies investigating on the psychometric properties of the evaluation tools. We also collected a few studies that were case-controlled, discriminant function analysis, randomized control trials, repeated measures, and also from the gray literature. So this is figure 3. We have tried to represent the number of tools used by different users according to the clinical disciplines. Almost half of the tools were used by occupational therapists. That was 48.8%. They are followed by psychologists, which include neuropsychologists and also psychologists. And only 7 tools were reported used by eye care professionals, such as neuro-optometrists, neuro-ophthalmologists, ophthalmologists, orthoptists, and technicians as test users. And only 4 tools were identified having physiotherapists as test users. 24 tools, that is 27.9%, did not report which health care providers were using the tools.
So all the information about the 86 tools we gathered through the process can be found in our table 2. We can find the number of articles that studied each tool on the first column. So if we take, for example, the Bell's test, it was studied in 10 different articles. The name of the study is found on the second column, in this case, the Bell's test. The area of vision measured can be found on the third column. For our example, the Bell's test, it measures unilateral spatial neglect in the peripersonal space. The domains, scales, and subscales and items, if there's any, can be found on the fourth column. The population on which the tool was used in the studies can be found in the fifth column. So in the Bell's case, the tool was used on first unilateral stroke patients. The type of tool can be found in this table, meaning if the tool is a diagnostic, a screening, or an assessment tool, like I described earlier. We can also find information on the setting in which the tool was used in the studies. So for example, for the Bell's test, it was in acute and tertiary settings. Also, we can find information on by whom the tool was used. So in our example, the Bell's test was used by neuropsychologists and OTs. You can also find the time required to administer the tool if it was mentioned. And information on how does the tool work. So is it self-administered? Is it standardized? Is it a paper and pencil test? And finally, on the last column, we have when was the tool used in the studies. So for the last column, it's important to keep in mind that the time frames that were reported are not recommendations of when the tool should be used with your patient. We simply reported the time frame used in the studies. So moving on to table 3. So this table has all the information about the psychometric properties of the 86 tools. So each column is a different psychometric property. So with some of the tool, we calculated the positive and negative predictive value, as well as the positive and negative likelihood ratio when it was possible. There are also, the ones that we calculated are also reported in the table. There's also a comment section which can be found on the last column of the table. In this column, we reported all relevant information about the tools that did not fit in any of the other columns from both table 2 and table 3. So in this slide, we wanted to present the tools that had the most studies on them, meaning that they were often used in research papers that we found that we included in our study. So we can see that the behavioral inattention test was the one with the most, with 16 studies. Following the BIT, we also had the line bisection test with 12, the Catherine-Bergigo scale with 11, and the Bell's test with 10. So the following slide shows the tool that had information on all the psychometric properties we presented earlier. This is to show you that there is not a lot of research done on all the psychometric property, as there's only few listed here, and we had 86 tools in total, which is why we think that there should be more thorough research on the psychometric properties of the tools in the future. Afterwards, we reported all the tools with 100% sensitivity. So we have the Ontario Society of Occupational Therapists Perceptual Evaluation Tool, and it was 100% and the cutoff of 110 and the cutoff of 70 and over. We have the Tobii Glasses Eye Tracking, monitoring task performance. We have the VR distro, the cancellation test, and the coin sorting subtest of the BIT for the right brain damage patient. The line cancellation test, the star cancellation test, the figure copying, the time telling, and the map navigation subtest of the BIT for the left brain damage patients, as well as the apples test. And for the tool that we have 100% specificity, we had the Azad perceptual evaluation tool, but this time with the cutoff of 60. The line bisection test as a subtest of the VR distro, the BITC, which is the conventional part of the BIT, the coin sorting subtest of the BIT for the right brain damage patient, and the time telling subtest of the BIT for the left brain damage patient.
So going back to earlier when we talked about Warren's hierarchy of visual perception, of the tools that we gathered, we mapped these against Warren's different levels of visual perception to see where each of these tools fell. Originally, we tried to map it on her 3 levels, but what we found were many tools didn't perfectly fit in just one level as to what skills they actually evaluated. Many evaluated several different visual deficits. So we created 2 additional levels that were combinations, foundation and intermediate level, and intermediate and high. We additionally had a couple tools that measure deficits from all different levels of vision, although they weren't holistic tools, meaning that they didn't assess all areas of vision. So what you can see is that the largest number of tools that we found fell into the upper levels of that hierarchy of vision. So we have 21 tools in the highest level, 16 in the intermediate and high, 25 in the intermediate, only 2 in the foundation and intermediate skills, and 14 as foundational skills. So table 3 accompanies that pyramid figure it's the same numbers, we just took the names of each of those tools as to where they fell into that hierarchy. So what we also did was we mapped those tools against the professional that was reported as using those tools and the level of vision which those tools measured. So these are the 3 most commonly reported rehab professionals, OT, psychology, and physiotherapy. We don't represent eye care in this figure just because they're not technically considered a rehabilitation professional usually. What you'll notice with the occupational therapist is most of the tools that are reportedly used by OTs fall into the higher levels of vision again. So higher, high intermediate, and intermediate. The same can be said of the psychology professionals. They tend to measure intermediate and high levels of vision. Physiotherapists, although we didn't have that many tools, tended to measure the foundational levels.
So based on the results as well as the information we gathered previously, we came up with some key findings that we wanted to highlight. So the first is that different professionals tend to focus on different levels of visual perceptual skills, with OTs and psychologists mostly using tools that evaluate intermediate to higher skills, while vision specialists focus on more of the foundation skills. And then in terms of comparing our scoping review with other existing review, we found it difficult to compare because a lot of the existing literature focuses on only a specific condition and a specific type of visual deficit, while ours was more broad and had a larger variety. However, we did validate findings in one review, which was by Hannah et al., which concluded that there were no gold standards for assessing unilateral spatial neglect and recommended clinicians to use multiple tools to assess the various aspects of unilateral spatial neglect. So indeed, nearly half of the studies that we found used either multiple tools or a battery of tools to assess visual deficit. And as observed when we did our data extraction, oftentimes individual tools may be just limited to a specific component of vision, which is why using multiple tools or a battery provides a more comprehensive evaluation. An example of tool combination that was seen multiple times was the behavioral inattention test, and as with the Catherine-Bergego scale, which are useful to evaluate different symptoms of unilateral spatial neglect as they focus on visual inattention and behavioral neglect respectively. For our secondary objective, we wanted to collect information regarding the timeframe when tools were administered. And although some articles did report when the tools were administered during the study, there were not recommendations regarding the optimal testing timeframe. And in addition, we realized that the prognosis of TBI and stroke could differ. So this means that the timeframe to use the tools for both conditions could differ as well. So therefore, we were not able to draw conclusions regarding the ideal testing timeframe when to administer the tool. And again, most studies that we found focus on one of the two conditions, so either TBI or stroke. So we found little overlap regarding the tools used for both. As for information relevant for managers, we found that the majority of tools were used by OTs and focused on higher skills levels. So this suggests that OTs are likely the first professional to screen for visual deficits in the rehabilitation setting. And so this supports Spear's findings that there is often a lack of formal vision assessment by eye care professionals in acquired brain injury rehabilitation. And so this means that patients may often be referred to vision specialists only once important visual deficits are noticed or suspected by the rehab team. However, this approach does not align with the Warren model discussed earlier. And this model highlights the importance of first performing a thorough evaluation of foundation skills prior to evaluating higher skills levels, because problems at the higher level may be caused by deficits in the lower levels. And once those deficits in the lower levels are solved, the ones at the higher levels disappear as well. So this suggests that it may be pertinent to involve vision specialists earlier on in the rehabilitation process, as they are experts when it comes to using tools that evaluate foundation skills. So we therefore conclude that to ensure a comprehensive evaluation of vision in acquired brain injury, it may be useful to adopt a multidisciplinary approach and increase the involvement of vision specialists in the process. It would also be important that the assessment results are clearly communicated between all team members, as vision issues can impact many aspects of rehabilitation. And when performing evaluations and interpreting results, clinicians should take into consideration all levels of vision. And finally, increase specialized training of rehabilitation professionals in vision evaluation could be helpful to improve the clinician's understanding of visual deficits, the different levels of vision, as well as their ability to recognize vision impairments.
So the study has several strengths. First, it used Warren's models to collect the data. The model is very familiar to many rehab professionals who work in the low vision rehabilitation, both as a theoretical and treatment framework. So it allows the results to be easily interpreted by the clinicians, and it can also serve as a quick clinical reference. Also, The study examined and compared assessments of visual deficits across multiple acquired brain injury conditions, rather than focusing on one specific condition. So our review can reveal important differences between what tools were being researched on TBI versus on stroke. And you can identify the gaps and the trends in the research regarding the assessment tools. Third, the data were extracted regarding the use and the development of assessment tools across different healthcare disciplines. This allowed us to identify, again, possible gaps in care and knowledge between clinical disciplines. And lastly, our reviews was also very comprehensive. It examined multiple areas of visual deficits and looked at more than one types of assessments. This is in line with recommendations by many clinicians and researchers in the field for the development of clinical treatment models and guidelines that stress comprehensive interdisciplinary visual rehabilitation following ABI. Nonetheless, this review has several limitations. First, due to the broad nature of the questions in scoping reviews, articles resulting from the search discussed several areas of vision and did not always focus on evaluation tools to assess a specific visual deficit in rehabilitation. Second, the review did not formally evaluate the quality of evidence gathered from the wide range of study designs and methods. And therefore, the results on psychometric properties of the tools should be interpreted with caution. And third, although the reviews collected from the preliminary search of the literature in Medline mostly came from the fields of ophthalmology and urology, only a few studies in ophthalmology were included in the synthesis of the review. This might be due to the search strategy omitting key mesh terms specific to vision tests related to physiopathology of vision disorders and vision pathways, often used by ear care professionals.
So some areas for future research. Firstly, as it was mentioned before, most of our studies were on stroke population and not so much on TBI. A big reason for this was we had to exclude a lot of TBI studies, as many TBI patients tend to be younger and therefore the study population was younger. If you remember, our inclusion criteria was that it had to be adults, primarily older. So this was a big reason that we weren't able to include many TBI studies. So we would recommend a similar review on a younger TBI population in the future. A second area for future research would be a more fuller investigation of psychometric properties of tools. As was mentioned, many tools only had 1 or 2 psychometric properties researched on them. Also, many newer tools that have been developed do not have established psychometric properties, especially in the last 5 years. A third area for future research would be to improve the accuracy and diagnosis of neuropsychological tests. Often with visual deficits, there's a variability of their presentation and it's not always linear. Therefore, if someone is only being assessed once at one time, an unrealistic presentation of their actual visual deficit might be presented, as visual deficits can fluctuate due to many different factors. A fourth area of research would be to establish an actual evaluation timeline and testing timeline for the multiple different ABI conditions. So to conclude, our key findings were to ensure a comprehensive evaluation of vision. Clinicians should make sure that they're using multiple tools together to encapsulate multiple areas of visual deficit. They should consider the level of vision that the tool they're selecting evaluates, remembering that foundational skills should be evaluated before upper level skills, and that involving multiple professional disciplines in both evaluation and with communication would be ideal. Thank you very much. And we'll open it up to questions.
Thank you very much. That was a great presentation. So if anybody has any questions, you can either write in the chat that you have a question. I think you can just ask away. Lynn Dawson asks if we can get a copy of the PowerPoint to share with with everyone after.
I think that's okay, unless our supervisors say differently.
No, no, that's good. That's good. You can do
Yep.
that, share that perhaps tomorrow after the Miguel presentation.
So we'll share that with the along with the recordings, the recording of the presentation that we'll share to all managers after we have put them all somewhere accessible. I was wondering, I know you discussed the combination, having a series of different tests to do the evaluation because of the different aspects. I don't know if you have any thoughts on what would be the best combination or what tests you would use first. From what you saw in the different studies.
I think it's hard to draw broad conclusions. Like we said, a lot of things, a lot of research studies focused on specific things such as spatial neglect. I mean, that was a big one. So I think it would depend on what a clinician's particular focus was in terms of their rehabilitation. Again, we saw a lot of trends overall of, you know, what does the tool actually measure? I would say in stroke, there are more batteries that are established, and they tended to have about 5 tools, I would say generally, in those batteries. I don't know if anybody on my team could jump in with any examples of those batteries.
Yes, so a lot of batteries, they include cancellation tests, especially for USN, and a lot of them use different kinds of cancellation tests, such as story cancellation test, letter cancellation test, and they also did a lot of like copy drawing task that was incorporated in the batteries. And in some batteries, they also have some functional tasks that I ask the clients to perform. And I would say that's kind of the general trend of the batteries.
I would say also it depends on what you're looking to assess, because sometimes we have a lot of batteries for driving that combine a driving test and a pre-driving assessment. There's also tests that are more for reading, so it really depends what you're looking to assess too.
Mm-hmm.
Great, thank you. There are some questions here in the chat from Megan. So she says, this is probably beyond the scope of your project, but are you able to recommend specific tools that you think we as clinicians should look into getting or look into learning more about, and which ones are easily available? So sort of encompasses some of what we discussed, but I don't know if you want to add anything on that.
I think for specific tools, it's hard for us to say. We didn't look into pricing, we didn't look into availability, so we can't answer that for sure. For specific tools, I think one thing that did come up is that often in the rehab milieu that there tends to be an emphasis on pen and paper tests, and that there's a lot that can be missed if you're only doing pen and paper tests. Because there's a lot of things that only will come up during behavioral neglect, or standing or using territorial or larger vision rather than just focal vision. So that's one thing for sure. Anybody else want to jump in with certain tools?
No, you said it all.
And there was another sub-question here. Also, other than the BIVSS, did you find other symptom checklists in the gray literature, and would these be easily accessible?
No, we didn't find any other checklist.
Not that had psychometric properties.
Yes.
Yeah, that needs to be precise because our search to be the evaluation tools and the studies need to have at least one psychometric properties to be included in our study. So we have excluded a lot of the evaluation tools that are being used, but that have not been researched on. So that's, yeah.
Hi guys, it's Ivy. I do have a question.
Go ahead, Ivy.
First, I'd like to congratulate you guys for your nice presentation. But one question that I have is that you mentioned the role of the vision specialists or the eye care professionals. But a few of the studies that you found on the foundation skills are actually being captured by the physiotherapists. Am I correct?
Yes, so I would like to say again, like one of our limitations, I would think, is that we have maybe omitted specific mesh terms in the search strategies that specifically are the mesh terms used by eye care professionals. So maybe that's a reason why our studies yielded a few studies that are written or that are researched by eye care professionals.
Mm-hmm. So if there are those few studies that regarding the foundation skills that the physiotherapist actually can assess or evaluate in a rehab setting, do you think that's something that us as rehabilitation something should have to look into in case we don't get like a vision specialist? At least we know from your studies, a few of your results, that the physiotherapists are actually touching upon on those areas of the vision, especially the foundation ones.
Yeah, definitely. Another reason that we didn't have a lot of physiotherapist studies, were often the physiotherapists looked at vision in conjunction with the vestibular system. And often their tools assess both at the same time. And since they were, for our inclusion, we only included pure vision and therefore weren't looking at vestibular dysfunction as well. Oftentimes we had to exclude those. But yes, I think there does seem to be more attention being paid in physiotherapy to those foundational level visual skills.
Thank you.
Thank you. If there aren't any other questions, I think we'll conclude. Have a good comment here. Great job and congratulations. You did a great project, very extensive. Look forward to seeing all of those results, because I think that there will be a lot of information there to be reviewed. So that was great. Thank you very much, and great job again.
Thank you.
Indeed, great job. Thank you.
Thank you.